I love that. Karen, what are yours?
Thank you. Good morning, everyone. Can everybody hear me okay in the back there? Yeah, okay. So it's my pleasure to be here to speak with you this morning. So I'd like to share with you the Canadian perspective of how we manage our air crew and specifically aeromedical risk. And I'm going to look more at depression and the use of antidepressants. So we'll start off with our question. I don't know if people have their clickers. Okay. Now, I expect this will likely be a guess for most of you, but hopefully by the end it will become apparent. So, which of the following medications are not approved in Canada for treatment of depressive illness in Aircrew? Is it sertraline, escitalopram, venlafaxine, bupropion, or citalopram?
Okay, I'll close it off there.
All right. Okay, so I thought I would start this off this morning. So for those of you who can't read it or still have your beer goggles on from last night or just are too tired to read this morning, it says, when I spend money, I'm happy. When I run out of money, I'm sad. I'm bipolar. So I think that we can all relate to this on some level. We all experience a wide range of emotions. There's things that are going to happen that are going to make us happy, things that are going to happen that are going to make us sad. We're going to experience a wide range of emotions in between, and this is completely normal. We're very reactive to our environments. And our mood states are often accompanied by other symptoms. So we can have physical symptoms, we can have emotional symptoms, we can also have cognitive symptoms. So when we look at our psychiatric syndromes, these are basically a constellation of these symptoms, but they have a certain level of dysfunction to them. So to have symptoms is normal. To have a constellation of symptoms that cause impairment and dysfunction, that's when we consider it to be more of an illness. And all of our psychiatric illnesses can affect cognition and judgment. And I think we often look at depression more of a mood disorder, but what is often quite profound is the effect that it has on our cognition and judgment. And part of what we're seeing is that a lot of the illnesses that we see in our young aviators fall within the age range that generally from mid-teens until late adulthood. And this is of particular interest to us as clinicians as it focuses on the important issue of safety. Now, it's not just to the individual, but it's to everybody around them. So in order to mitigate these risks, we have to be vigilant to ensure that people are not cognitively impaired and that their processing abilities aren't impaired as well. So we have to make sure that they're able to make decisions clearly, they have situational awareness, and they're free from the presence of distracting symptoms. Now, depression actually has the highest lifetime prevalence of any of our psychiatric disorders. It approaches around 17%. The average is around 12%, so that's about 1 in 8 people. Generally happens from late teens to mid-adulthood. And what we do know for depression is that your chances of having a successive episode increase with each episode. So if you've had one depression, your chances of having a second one are about 50%. Then you have a second one, your chances are about 75%. And if you have a third one, your chances are 90 plus. What we also know is that the more thoroughly that you treat depression until remission, the less likely the chance that you'll have a recurrence. What we also know is that in terms of depression with untreated episodes and with chronicity, you actually get structural brain changes that actually cause hippocampal loss, representing a form of brain damage. And that actually happens about the 4th or 5th episode. So it's very important to be able to treat until remission. Now, the World Health Organization recognizes depression as one of the leading causes of disease burden worldwide. If you look at the arrow there, it ranks third, only secondary to lower respiratory infections and diarrheal illnesses. And this is often reflective of the healthcare in the developing world. They estimate that by the year 2030, that depression will rank number 1 and account for about 6.2% of dailies. Now, as we heard in earlier lectures, dailies are basically disability-adjusted life years. So you can think of these as the sum total of potential years lost due to either premature mortality or productive years lost due to disability, or 1 daily equals 1 year of healthy life lost. So we're looking at about 6 years lost just because of depression. So this is one form of a depression test. It says, "This is awesome, doc. I scored 81 on the test. I don't do well on tests. In high school, I was a D student, and a score of 81. That's almost like an A, right?" It says, "I think you should come with me now." So this isn't an uncommon scenario, either if you're a flight surgeon or a psychiatrist. We often administer baseline tests for depression, and really it's the score to the individual doesn't really have that much significance, and that's for us to apply. But I think what Aircrew do know is that once they come through our doors, that they could be grounded at any time. And if they present with depressive symptoms, it's quite likely that they're going to be grounded. If they're diagnosed with depression, it's almost certain that they're going to be grounded. And for them, a grounding means no flying, generally for an indefinite period of time, so they're generally very reluctant to come forward with their symptoms. And so that's not generally risk that they're willing to take, but that risk actually translates into a flight safety risk. So because of the various factors, I would say, that are associated with psychiatric illness, specifically the stigma, and in our case, the people that we see, the amount of time it takes to get somebody into treatment, the amount of time it takes them to undergo treatment, the prolonged grounding period required for treatment, and then the amount of time that it takes for them to come off of grounding, they're generally reluctant to come forward with any of their symptoms. And prior to 2000, the incidence of diagnosed depressive illness in our aircrew was actually less than 1%, which was quite interesting given that the incidence in the general population approached around 20%. So what we took away from that was a few things. Aircrew were either treating themselves secretly somehow with other medications, they were self-treating with other means, generally alcohol, which compounded the problem and caused further problems themselves, or they continued to fly while they were depressed. So under limited supervision in 1990, the Australians actually began to allow their licensed aircrew to fly while taking antidepressants. And a review that was done about 15 years later actually showed no increase in pilot attributable accidents while they were taking these medications. So this was interesting data, and I think it started allowing other countries to start asking similar questions. And in fact, Transport Canada and the Canadian Forces were actually among the first of the aeromedical agencies to allow their aircrew to fly while taking antidepressant medications. And now there's becoming an increased acceptance worldwide of this practice, but it's not practiced everywhere. The Central Medical Board convened a meeting in 1999 with many of its key players because they recognized that trained aircrew was a very valuable resource. And the concerns were that depression, with its high prevalence, was leading to a loss of these resources. And I think more importantly, what they were looking at was that they recognized that there was a concealed prevalence of depression. People just weren't coming forward to that with that. And so they recognized that that was a flight safety risk. So what they were looking at doing was evaluating the use of antidepressant medication in individuals while allowing them to fly once their symptoms had resolved. And they would continue treating a full course until their treatment was complete in order to prevent any recurrence. And they were doing this in order to encourage people to come forward and actually get proper treatment for their illness. So what came out of that meeting was that we could trial certain SSRI medications under specific guidelines, and we would assess various performance measures. We chose SSRIs that were based on lack of aeromedically concerning side effects. So we didn't want drowsiness, fatigue, those types of symptoms, although they're short-term. But as we'll hear from one of our colleagues later this morning, fatigue is already a problem in Aircrew. We don't need to compound that problem. So we started with sertraline and bupropion initially, and later citalopram and escitalopram were added. So for consideration to return to flight duties, those are the only 4 recommendations that are actually recommended at this time. Studies were undertaken in Toronto under fairly strict research conditions, and the performance evaluations were done looking at serial subtraction, logical reasoning, serial reaction time, and then they did a multitasking test, which was designed to simulate the information processing that would be required in flying. The findings had indicated that there really were no significant effects on any of the performance measures. The things that you would expect from starting a medication of any type, short-term side effects, generally resolved within a few weeks. What they had noted was the sleep disturbance, dry mouth, and drowsiness, but these were all transient. So what came out of this was that we developed flight surgeon guidelines for limited use of SSRI medications in Aircrew. And I'd say that this is an underestimate because over the past decade, we've returned well over 50 members to flying duties and still allowed them to take medications. So when we're doing this, we follow a standardized protocol. They generally have an initial evaluation at the unit level. At this time, we would encourage that they have a consult or referral to a mental health specialist or a psychiatrist. And the aim is that once they're clinically stabilized, their symptoms have resolved for a period of at least 6 months, then they can be considered to return to flying duties and continue taking these medications. Now, I'll point out that this protocol is for trained aircrew, and we would treat an initial episode and a recurrence that's not complicated by psychosis, suicidal behavior, or have a significant anxiety component. When we're looking at applicants or people that are going for selection, we do recognize that people could have one depressive illness, but a recurrence is actually a disqualifying condition. And we do use the SSRIs for other indications, most commonly for our anxiety disorders. And in fact, we do have aircrew who have anxiety disorders who continue to fly, but these are generally assessed on a case-by-case basis. Now, we've heard throughout the week of different countries, different medical category systems. In order for me to help show you or understand how we generally administrate our aircrew, I'm just going to give you a brief overview of our medical system. So we have minimal medical standards for our aircrew and all of our CF members that are based on their trade. So it'll say what level of care is required by this member, how frequently do they need to be seen, who do they need to be seen by. We have a geographic factor, which is basically the proximity within which you need to be to medical care for your condition. An occupational factor, which outlines the limitations or tasks for your specific trade. And these are generally given by the flight surgeon on our annual medicals, or if they come for any sort of condition that requires any restrictions. The air factor addresses the medical employability for flight duties. And this is actually given by the Chief of Air Staff, or the CAS. These medical employment limitations are generally temporary. They're usually in effect for 6 months, or they could be permanent depending on the condition. And they're in effect until they're reassessed. So they don't automatically expire, they don't automatically renew, but they require reassessment, and that's generally around 6 months. So the process of actually returning to flying duties will depend on the type of aircrew that you are. So we've generally have it divided, I think somewhat arbitrarily, into Group A and Group B aircrew. So Group A aircrew you can conceptualize as being those integral to the actual mission at hand. That'll include your pilots, your flight engineers, SAR-techs. Group B aircrew is the supporting aircrew. They can either be in flight or on the ground. There'll be people like your flight surgeon, flight med tech and that type of support to the mission. So regardless of what group you fall into, you'll be under medical care from the start of treatment until it's finished. During the initial period and for the treatment period, you'll be grounded for 6 months and you'll be unfit aircrew duties. At this level, you're managed at the base or the wing level. It's generally by the flight surgeon or with the addition of a specialist. When it's time to consider returning you to flight duties, you have to be symptom-free for 6 months, on a stable dose of an approved medication, and depending on what type of aircrew you are, you'll fall through a different assessment phase. This is just a flow chart, which I'm going to go through and elaborate on my future slides. But generally what happens is that the flight surgeon will make a referral for an aeromedical psychiatric evaluation. Once that's completed, the recommendations will be forwarded on to our Air and Undersea Medical Board, or the AUMB. Following that, they will have a clinical review, and that will include a neurocognitive screen. And those recommendations will also go to the AUMB for review. And those recommendations are forwarded on finally to the 1 Canadian Air Division surgeon for final aeromedical approval and assignment of the air factor. And again, that's more for the Group A aircrew. For Group B, those are generally not following the same process, but they're assessed at the base or wing level, but their final disposition also comes from 1 CAD. So for Group A aircrew, the aeromedical psychiatric assessment, that's an occupational assessment. It's not for diagnosis, it's not for treatment recommendations. And what these referrals generally read as, we have this individual who is taking these medications, these are their current symptoms, are they fit to return to flying duties? So that would be the typical referral that we would get. And then those recommendations are forwarded on to the AUMB. Generally the next day we try to do it just because of geography, for them to go for a clinical review, and then they'll have the neurocog screen done, and then those results also go to the AUMB. Now, provided that the recommendations from the psych assessment and from the clinical review are favorable, if you're non-pilot aircrew, you can continue under medical care, continue taking your medications, and you'll be returned to unrestricted aircrew duties. If you're a pilot, this is done a little bit differently. These are all done on a case-by-case basis, and the outcome is generally a restricted category, fly as or with co-pilot, mostly allowed for transport your unfit TACHEL, maritime rotary wing, or tactical fighters. Final recommendations for air factor go on to the Canadian Air Division surgeon. Group B, again managed at wing level. They don't go through the same process. Once they're clinically stable on a stable dose of medication, they can be returned to an unrestricted flying status. And again, their final approval comes from the 1 Canadian Air Division. In terms of discontinuation of medications, which we generally do with a very slow taper, people would remain under medical care with just temporary restrictions, but they would remain on flying status. And then after 3 months, so that gives us a surveillance period just to see if there's going to be a recurrence of symptoms, they can generally be returned to unrestricted flight status, remain flying, and if there's no clinical concerns, there would be no medical employment limitations if they remain stable. There are certain individuals that might require longer term medications or even lifelong in order to prevent a recurrence. They are able to remain on aircrew status if they remain clinically stable. All of these are reviewed on a case-by-case basis, and the permanent limitations that go with that are that they'll require annual follow-up with the CFEME or the Medical Consult Service in Toronto. So that generally gives you an overview of how we manage our aircrew. And we recognize that depression, it's a serious illness. We recognize that it's quite common. It affects our population probably more than we're actually aware. And what we're trying to do is create an environment where individuals will feel more comfortable coming forward with their symptoms, allow treatment, and hopefully they won't feel that when they come for treatment that this would be either an end to their careers or that they're going to lose their flying status indefinitely. And I think most importantly, we recognize that the risks to flight safety of somebody who has untreated depression far outweighs the risks of somebody who has depression, who's on treatment, and continues to take these medications either while they're in the cockpit or whether supporting flying operations in any other capacity. So I'm just going to bring up the question again. So which of the following are not approved in Canada for treatment of depressive illness? Hopefully you were able to glean that from the presentation. Oh, very good. Okay, that is correct. Can we just advance the slides one more time? Oh. Just thought I would end with this. This is sort of a sign of the times. Bad humor. Shut off your cell phone, GPS, iPod, and Bluetooth headset. Then let me know if you still hear the voices.